Good evening and welcome to another episode of Prime Focus, a spotlighting program that highlights issues of concern to individuals, families, and communities, bringing greater awareness and education with a view to improving the lot of others through anticipated positive actions. It's a joy to have you join us today, and we believe that you're going to have a wonderful time with us. We'll be looking at dealing with bipolar disorder or bipolar affective disorder, understanding it and how you deal with it and support people with that. Herbert Mwebe is a senior teaching fellow and a senior lecturer in mental health in the Faculty of Health, Social Care and Education at Middlesex University. Herbert's teaching and research interests focus on best practice relating to improving physical health outcomes in severe mental illness, the safe use of psychopharmacological agents, and mental health promotion. Herbert has worked in various UK National Health Service settings, including general practice and secondary and primary care services. He is a specialist clinical advisor to the Care Quality Commission, CQC, a role in which he supports the CQC to undertake community and health inspections for mental health providers. He is an editorial board member for the British Journal of Mental Health Nursing and an external examiner at Bournemouth University. He is also a specialist member of the Mental Health Subchamber of the His Majesty's Courts and Tribunal Service. Herbert, thank you for joining us again. It's a joy to have you after you started us off on this whole Prime Focus series. And people have been asking about the topics that you talked about before. But today you're here for a different subject altogether. But we are delighted to have you. Right. So maybe you want to say hello to our audience quickly so they can hear you.
Thank you, Rexford. It's always a pleasure to feature on your really much needed community engagement podcast, because many of the things that you talk about, the people that you invite, talk to the heart of our communities. So when you asked me again to feature again, I didn't hesitate to come and be part of this. So again, thank you very much. And I just want to say hello to all of our viewers, those in the UK and outside the UK. You're very much welcome.
Yes, thank you so much, Herbert, again. Herbert, let's get straight into business because I have a couple of questions here that I'd like to throw to you. We keep hearing the term, oh, this person behaving a particular, oh, they're bipolar. I guess I started hearing that from my teens. Oh, the person's bipolar. Anytime somebody behaves erratically, they're bipolar. So is it a term that has been thrown around loosely? Or what exactly is bipolar affective disorder?
Bipolar affective disorder is categorized as one of what we call sort of severe forms of mental illnesses or a mental disorder, which by its nature can be recurrent. And recurrent, I mean the episodes of bipolar, which I'll talk about as we go along. For people that actually suffer from this mental disorder, the episodes they happen every so often, depending on really some of the risks that I will also talk about. But essentially, it is a recurrent disorder which is characterized by, for most sufferers of bipolar, repeated sort of psychiatric symptoms involving episodes of mainly mania and a mixture of what we call hypomania and on the other spectrum, depressive futures. But for people with bipolar, sometimes you can have that they have mania, hypomania, or a mixture of both. But also in between these episodes, there may be episodes of what we call inter-episode recovery, where they may be fully functioning, they're able to go about with their day business. So really, it's in the UK, it's a rather complex chronic enduring illness, which can affect people's ability to actually live a normal life per se. And in fact, it is also quite, in a way, in terms of the presentation, very similar to another condition called schizophrenia, although with schizophrenia, we see predominantly psychotic symptoms, obviously being the major focus of assessment, treatment, and management. So that's bipolar, really.
Right. You use the term mania and all that, and hypermania. I know somebody would say the person's a maniac, meaning the person's crazy. So what exactly is mania? When you say mania, is it, because I guess audience, some people might wonder what exactly is this mania you're talking about?
Now, for clinicians that assess and manage people with bipolar affective disorder, they will be interested in terms of categorizing the clinical features.
Motion detected at the front door.
The clinical features. I apologize.
Someone is at the front door.
Apologize. That's Alexa,
right.
but it's off. So categorizing the symptoms of bipolar affective disorder, we want to understand the clinical features, and so the terms mania and hypomania come about for us to understand sort of the degree of those symptoms and how those symptoms do affect the person's ability to really negotiate, navigate their life, but also at the same time how those clinical symptoms can affect the ability to relate to other people. So mania is essentially characterized by elated mood. So people with particular mania have overactivity. Sometimes their brains are over racing, and in some people they may report irritability. So they may be quite sort of touchy and quite angry, and mania tends to sort of manifest for weeks, even up to 2 to 3 weeks. And sometimes with mania as well, people may have pressure of speech. And particularly, one of the things that I think when somebody is going through a manic episode, disturbed sleep. So because of that increased energy and irritability and overactivity, sometimes the compromise sort of that would come at an expense of disturbed sleep at night. And most of the patients with mania actually do talk about feeling extremely tired because they haven't really slept. On the other hand, hypomania it's very similar to mania, but it's of a lesser degree. So the degree of mania is higher, and in terms of symptoms, but if you think about hypomania, it's kind of it's slower. So again, things like irritability and pressure of speech and disturbed sleep. In hypomania, we see that those features are there, but they're not, as prominent as would find in mania. So different degrees in both terms. And then depressive symptoms, so people that go through manic episodes, they can come from being extremely high, very irritable, loss of energy, and they may have poor concentration, and that could actually affect or sort of affect their productivity. For example, if they are going to work, if they have jobs, they may struggle to actually focus at work. They may struggle to sort of, chair meetings. They may struggle to actually be in a workplace settings where they're able to sort of do their day job. But because mania sometimes can manifest for a week or 2 weeks, what tends to happen that too much energy and excitement and the racing thoughts needs to come down. So, and that's why we often reference the depressive part of bipolar affective disorder, because what tends to happen, patients go from that trajectory of being extremely high to going extremely low, and this is where depressive symptoms come in. And in fact, what we used to call this manic depressives. This is where the term comes from. So mania meaning those elated overactivity, symptoms of increased energy, and obviously anything, those symptoms will come down into depressive futures for people with bipolar. So, but the nuance in now, the term that we often use is bipolar affective disorder. And in fact, in literature and most of clinical textbooks, we reference bipolar affective disorder as a more acceptable term. In fact, the ICD-11 and other diagnostic criteria, they reference bipolar affective disorder more than manic depression.
Okay. Thank you so much for that explanation. I think part of it was because sometimes terms are thrown out loosely to the lay people. So
Yeah.
certainly bipolar disorder, bipolar affective disorder is not just a regular mood swing of somebody. And now sometimes maybe women go through mood swings at certain times of the month and things like that. That's got nothing to do with this.
No, not Rexford. There is something very distinct about sort of the mood disturbance regarding bipolar affective disorder, where if it is persistent on a daily basis and the person's mood, particularly if it is extremely high, where there is overactivity, too much energy, pressure of speech, to a point that it is persistent, it is there every day, most days of the week, the person wakes up. In fact, even if they don't wake up and their sleep is compromised by having that too much energy, where by the following morning, the following day, the individual is unable to function normally, and there's a pattern that this is not a one-off, because when you reference things like obviously women who are going through maybe menopausal sort of periods, or even the monthly periods, or even if you're suffering from sort of any stress related reactions, some of these things may be short-lived, but there's something about mania which is persistent. It's there every day. You wake up, the person, in fact, the family members can actually tell every single day, every single minute, that something is not right, particularly if there is a lot of overactivity. And in fact, the other thing I forgot to mention, that in fact, in some cases of bipolar affective disorder, we've now come to know that some patients may also experience psychotic symptoms. So we tend to see psychotic symptoms mainly in psychotic disorders, for example, schizophrenia mainly, or psychosis, but also people with bipolar affective disorder. Sometimes some of them may experience psychotic symptoms, for example, hearing things or seeing things that are not necessarily there, and so on and so forth. So it is a rather complex illness that we cannot just reduce to just your everyday, mood disturbance, if that makes sense. Yeah.
Thank you for really digesting that for us. Right. I want to follow that up with another question here. The signs and symptoms of this. I know you've touched on a little bit on the psychotic side, and then you said a little bit here, but are there any other things that can help somebody clearly define, from either medical position or something to differentiate it from something else? Or is this just the fact that if it's consistent, as you said, over a period of time, not a one-day factor, then you can begin to look down that line?
Yeah, that's a very good question, Rexford. But I've briefly touched on it. But in terms of clinical, the clinical assessment and diagnosis, I think the thing to say here, I think people, clinicians, particularly psychiatrists and psychologists and people that work within mental health services, I think we are always too careful not to just label anybody with maybe one or two, three symptoms of maybe mania, the things I've talked about, for example, overactivity, irritability, or even if somebody has pressure of speech. That pressure of speech is really where the person is continuously talking, and if you try to interrupt them, you are unable to interrupt them because they've got that pressure of speech. They feel the need to to make conversation. So there is a personalized approach where not everything has to be put down in a box to fit a mental disorder, if that makes sense.
That's right.
Because again, the interpretation and understanding of how mental illness is conceptualized really it comes from particularly how we, in a way, we are as people within societies, cultures, races, and particularly thinking about our religious sort of background. So, but putting that to one side, it is important for us to not overly diagnose people, but to understand, first and foremost, whether any deviance in terms of their behaviors, their thinking, their emotional presentation, is it relatable? Is it because of maybe an environmental thing before we can label? We can sort of say, well, this is a mental disorder. But generally, to answer your question, if the symptoms, for example, for mania, particularly if there's overactivity, lack of sleep, and pressure of speech, and there is sort of an increased overdrive, and in fact, in some cases, patients may just report a degree of social inhibition, hypersexuality, and there is a risk to themselves, a risk to others, particularly where there is a concern about welfare, suicidality, So again, when you have increased energy, you may feel, in fact, sometimes patients may feel invincible. They may take, not consciously, but they may take sort of sometimes life-changing decisions because they're doing that within the illness. They're not really understanding. So we often say impulsivity, For example, I remember many years ago, I cared for a patient who was a stockbroker, and obviously there's a history of mental illness in their family, and he spent a good 50 grand, in 2 months, 50 grand in 2 months, just like that, But I remember when his parents brought him back from somewhere, he came back into the country, he could not possibly remember where all the 50 grand had disappeared to, but he spent it, And there is that degree of impulsivity because you feel extremely, creative. In fact, one of the things that you probably maybe have heard in the media is that we know that there are many celebrities who are extremely creative and they've got bipolar. So the increased energy, increased sort of alertness, in a way, for most people with a bipolar, works in a way in their favor, particularly if they are within the art industry, because if you stay up at night, that might compromise your sleep. You're not able to sleep. But there's something about bipolar that makes some people overly creative. And in fact, I can mention quite a few celebrities who are bipolar, and they categorically say that when they are on the high, when they're going for a manic episode, they have extreme creativity. They have ideas flying about, and in fact, Kanye West does talk about it in one of his commentaries about dealing and managing bipolar illness. So, but just to say that if the symptoms are persistent and they're affecting the person's daily activities, daily living, and there is a degree of risk in terms of thinking about suicidality and self-harm, and there is general worry and welfare about the person, it is very likely that the family members or maybe the practitioners that know that person will probably maybe want to reassess him, to provide care for him. But in terms of the depressive symptoms, so the depressive part of bipolar, Rexford, is actually very similar to major depressive disorder. So major depressive disorder is also one of the major clinical mental disorders we separately assess and screen as a disorder itself. But in terms of symptomology, in bipolar of depressive pathology, they are very similar. So again, if patients come from really being high, they may feel low, they may lose confidence, they may feel the entire world is against them, and that there's a degree of apathy, social withdrawal, and most often, sometimes that can affect their appetite. They may, refuse to eat. They may not feel like engaging in many things. But again, that is very kind of the expected pattern of bipolar, particularly where bipolar 1 and 2, which I'll talk about later, is concerned. So most patients who have a high, you would expect, in fact, as a clinician, you would expect that they'll come low, and you have to prepare for that to support them in terms of obviously managing those symptoms. And the psychotic symptoms I talked about, so again, it could be delusions, hallucinations, and those sort of auditory hallucinations. They may come in any sensory modality, and in psychiatry we call them sort of either auditory hallucinations, visual hallucinations, or tactile hallucinations, where the individuals may see things, but for you, who's not hearing or seeing these things, you don't really see them. So again, although not everybody who has bipolar will experience psychotic symptoms, we know that some patients, in fact, I think literature says that about 3 to 5% of patients with bipolar will manifest or present with psychotic symptoms. That also can be complicated by psychosocial factors, again, substance misuse, and so on and so forth.
Wow, it looks like it's a whole world in itself, talking about this whole bipolar.
Yeah.
I didn't know it was so deep, that we possibly outsiders just touch on the surface. So I know you've referred to having celebrities and all that. How common is it? I mean, generally, how common is this in the UK, or maybe if you have some global information as well? Does it affect maybe particular communities, or just can hit anybody?
I mean, bipolar is fairly common, particularly in the UK. But compared to other common mental disorders, for example, major depressive disorder, or what we still call clinical depression, we know that depression or major depressive disorder is a lot more common than bipolar. But bipolar, as I said, is common, and around, I think, 1 in every 100 people in the UK at some point will suffer or report or be assessed as having clinical features of bipolar. And one of the things I think that have been asked in the past before, not just only bipolar, but other mental disorders, is that how early can anybody present with a mental disorder? And I think the literature really sort of shows that, people can show signs of symptoms of mental illness even from a very young age, children from even the age of 10. But bipolar itself can occur at any age, and it often develops between the ages of 15 and 19. Very sort of, I think, consistent with most sort of adolescent into adulthood, mental disorders, and particularly for men and women, we know from all backgrounds, are equally likely to develop bipolar. And I think we don't have currently literature to suggest that there's a higher risk of developing bipolar in men or women. I think men and women are affected equally the same. And I think Bipolar UK, which is a dedicated charity that looks into sort of research and support pathways for people with bipolar, I think indicated, I think when I last read, that there is about 1.3 million people in the UK who are currently living and being treated for this condition per se. And many of these are living with chronic symptoms, which require, again, so what we call secondary mental health services to, to follow these individuals to ensure that obviously they're managed and cared for, and so on and so forth. But I think on the world stage, bipolar, like cancer, is one of the leading causes of disability. If you think about it, the amount of people, so 1.3 million people with the UK, if they have chronic features of bipolar, it is very likely that they may not necessarily be able to invest and produce and invest back in the economy. So again, there is that degree of disability that some of these long-term conditions bring about for the individual, as well as thinking about to the economy as well. Never mind obviously the uptake on services, and particularly thinking about COVID-19 and the pandemic situation we lived through. We know that this was an extremely difficult time for people with mental disorders, mainly because of the structures of mental health services were in a way affected because of the lockdown. So again, you had people like psychiatrists and community psychiatric nurses often unable to undertake their community visits, to look up to check on patients with mental illness, and that in a way affected continuity of care and so on and so forth. So bipolar is fairly common in the UK, and it really does significantly people who may not necessarily be engaged in services and they're not currently taking medication, that can have really dire consequences on their lives per se.
Wow.
Yeah.
Interesting analysis there, and even the effects of it and all the other stuff that you're mentioning there. I was going to put up something here that I wanted you to have a look at, but I think you touched on that already. But maybe I'll rephrase the question. This was the original question, but based on what you've said, I wanted to change that. And if you read it here, it talks about there's a common misconception that children cannot have it. But I've just heard you say as young as 10 years old, you can. So I guess parents need to either get some information. I'm not sure is there information out there already. I'll come to that part of it that people need to know. I think part of what I was interested in is the misconception. I also heard you say it can come at any time. So does it mean an adult can develop it?
Yeah. So I mean, can I just pick up on the issue about children,
Right.
and then I'll probably move on to talk about some of the causes and risk factors. But the other thing I just wanted to reference here, again, thinking about how serious this mental disorder is, given the representation in the UK population, that particularly thinking about the implications of having this disorder is that it does actually increase an individual's risk of suicide. So if you think about people that currently are diagnosed with bipolar, let's say maybe 20 of them are currently well managed in the community, maybe say, let's say another 20 are not really engaged with services, and they don't have that sort of close-knit family support or carers, whether within social care services, that's the degree, the impact of that illness, where there is lack of social care support as well as healthcare support, can actually increase the risk of suicide by up to 20 times if the person has this diagnosis, and that's Rexford. That's massive. That's massive. And we know, particularly for bipolar, that the times where people are extremely vulnerable, is particularly during manic episodes where they have increased energy, and in fact, when I worked in inpatient mental services, many of my patients who sadly, I remember maybe 5 of them who committed suicide. This was often during the period of mania, and quite a few of them obviously, would go off bridges, and they think they're flying. They believe they're flying. If you believe you fly, you can fly. You can go as high as maybe 20-story and all of that. So this is an important point, particularly for family members caring or looking after individuals with bipolar. If you suspect that your loved one is becoming a bit slightly manic, they are not sleeping, they're not eating, there is increased thought, if there is also risk of substance misuse, and these are kind of risks that we often see, particularly in mania, where users may overly overcompensate by using substances. So that always is a risk where suicidality is increased, but also in extreme depressive sort of states, that also is a risk. So in both really components, one, we ought to be able to sort of monitor our loved ones, to ask constantly. Don't be afraid to ask questions. How are they feeling? And don't be afraid to ask straightforward questions, particularly where you may say, "Hi, Herbert, by the way, Are you hearing voices? Do you have any thoughts of harming yourself? Have you made a plan? So we have to be very clear to the point when we are assessing them and making sure that we get that information to hand.
Wow. Thank you so much for that, and for also enlightening us about the thing to do with the children bit of it. You talked about risk factors, and I was going to come to my next question. But before that, I wanted to put up something for you, if you don't mind. I just wanted to show you a little chart here.
Yeah.
And this is from a reputable organization in Denmark. That's a study done. My interest there was more the last two columns there, which talks about bipolar disorder and also psychotic. And he's saying that the use of weed, I'm not being political or anything here, this is just figures I'm using from research, that weed has kind of impact you a lot more. Would you agree with this?
I mean, I totally agree, and there's obviously quite a lot of, I think, pro movements about the use of drugs, particularly these sort of dopamine enhancing drugs, amphetamine and weed and Charlie and so on and so forth, in terms of self-medicating for symptoms of mental ill health. There is obviously there is, maybe that's another show altogether, sort of medicinal cannabis, cannabinoids, which are obviously extracted from cannabis plants, but they're made safer, particularly used for medicinal purposes, and that there is some research, some promising research, that some of that, sort of really well researched cannabis can help, in terms of medical conditions, and mental disorders is being fronted as one of those. The issue, I think for most people, particularly people that may not necessarily engage with literature, is that there is a belief that even your cannabis you buy off the street, so you go to Camden Town or you go to Brick Lane and you buy that cannabis off the street, that cannabis is safe, that it can equally achieve the same benefits, and that's where I think the problem comes in, because substance misuse is known, in fact has far more impact on the brain, on the neurochemical pathways, which actually for me as a scientist, I understand more about how the brain works. And in fact, these drugs, by increasing neurochemical pathways, so neurotransmitters that within the brain help to stabilize neuronal communication. So for most people that use drugs, particularly those drugs that increase those neurochemical pathways, they are far at greater risk, of not only mental illness, but even things like stroke, particularly where there is an interaction of the person's individual vulnerability in terms of genetic composition. So we know that we are born with these genes from our parents, and we have particular sort of DNA. Genes are in our DNA, but we know that in terms of how those genes then become expressed, we've known that science has told us for many years now that it's not so much about what we are born with, but it's so much about also the environment. So I used to care for many people who I remember GPs referring to me, people in primary care, who were only being referred to me because of one primary problem of substance misuse, and obviously you assess them, how much are they smoking, do they wish to cut down on their cannabis, or maybe on cocaine or heroin, but at that point there is no mental illness, and I remember categorically explaining to them that if you carry on not reducing or actually ceasing to stop some of the substances, it is very likely that you will develop a mental illness. And Rexford, that was the case. So again, to answer your question, so one of the risk factors for developing mental illness is actually substance misuse, among other things, particularly if the individual has a history of mental illness in their family. So again, individuals with family members with a mental illness, who have suffered a mental illness, they are at far greater risk of obviously developing a mental illness. And these are some of the things in our communities we can be aware of, we know of, to help us to prepare ourselves, not prepare ourselves, but also to avoid certain, environmental risk factors that may expose us to some of these, physical medical problems, per se.
Mm-hmm.
So yeah, to answer your question, yeah, I probably would want to avoid as much as possible, if I had bipolar affective disorder, to cut down on my weed, and we know weed comes in different forms. We want to cut down on that, party drugs, GBH, all of that stuff really does not agree with, the neurochemical pathways in the brain. And in fact, mental illness, if you think about mental illness is one is emotions, how we think, and how both of those your thinking, your emotions, how they affect your behaviors. So if you think you are a white person, but you're black, you're going to want to act like a white person, and that may actually affect your ability to socialize with people that you don't regard to be of the same color as you. But that's not reality, if that makes sense. So it really, mental illness, if conceptualizing mental illness can help us to understand how our emotions, how we think about life can actually affect our behaviors. And what I'm trying to explain, that a lot of these things around us, psychosocial stress, drugs and alcohol, can actually reflect and influence, the etiology and the incidence of mental illness.
Oh, well, thank you. Thank you so much for that. I know that was one question, and I know it's led to many other things there. So I guess you've talked a lot about the risk factors there. What about causes or things for developing bipolar disorder? Are there any sort of triggers as well, apart from maybe the substance abuse, alcohol, and things like that?
Yeah. Thank you for that question, Rexford. But I realized earlier when you asked about the risk factors for children, I didn't really fully explore that. So if you don't
Sure,
mind,
go ahead. Yes.
yeah. So again, bipolar really is a growing issue in children, and with young people, particularly young people, being more likely to screen positive for the symptoms I've talked about. In fact, between the ages of 16 and 24, we know this is where we see, an emergency, and where we start to see clinical symptoms I've talked about, so mania or hypomania, and that we know within that age, those young people are 8 times more likely to screen positive for bipolar, like the adults. The other thing to bear in mind is that, when we're assessing and screening for symptoms of bipolar, so mania, depressive pathology in children, that due to lack of guidelines to diagnose children, sometimes clinicians, so again, psychiatrists and maybe psychologists and mental health nurses, sometimes may rely on adult frameworks to diagnose or to confirm whether there is bipolar in children and maybe young people. And the problem is sometimes the symptoms in children may be slightly different, to adults, and using adult criteria can sometimes be problematic, as clinical presentation, obviously, as I said, in children may be slightly different. For example, children are more likely to have maybe continuous sort of mixed, what we call mixed states, where there is hypomania and a depressive episode. So children are more likely to have sort of a continuous, those episodes of mood cycles, and particularly in children, sometimes it may be more severe irritability, where sometimes the parents may think, oh, well, it's just a growth spurt, they just maybe developmental or conduct disorders, and that they may not necessarily have clear episodes where they may be well, if that makes sense. So for adults, adults with bipolar, they may have mania, and that mania may last for about maybe 4 or 5 weeks or even 3 weeks, and then they may be depressed, and with the right support, they may feel better again. So those inter episodes, recovery, are more clear in adults, but in children, sometimes those periods may be quite difficult, to obviously to confirm. So it is important, I think, particularly if you're a parent, for children, particularly you suspect of maybe suffering from not necessarily bipolar, but maybe a behavior or sort of a change, just to maybe have maybe a diary or maybe a notebook where you can record any variations in the child's mood, particularly if there's irritable mood in children, and also low mood, and sometimes signs of depressive pathology as well. So again, are they not eating? Are they not sort of self-caring? If they're obviously lacking energy, and particularly for children where there's rapidly changing moods lasting a few hours to a few days, that is always something to note. And explosiveness, if a child is explosive, really angry and bashes things, and this carries on for lengthy periods, and sometimes that can be not necessarily a sign of bipolar, but you want to keep a diary of all of those, changes in behavior, and particularly where there is a history of separation anxiety, again, single parent families, all of those issues, and often sometimes where we call sort of defiance of authorities. It's a common thing now in conduct disorders, where children may be really sort of very against authority, and they're irritable, and maybe they may be abusive, very agitated and destructible. As a parent, you really want to keep an eye on those symptoms, record them down. How often do they develop? Do they develop after school, before school? Is there a link between the child's mood and sleep? Are they sleeping well? Is there a link between the child's lack of eating or overeating with sleep, or a lack of sleep? Is there bullying? As a parent, you want to record all of that information, so that when you actually go to see the GP or the child psychiatrist or psychologist, you have that pattern, to fall back on. But yeah, so again, there's always a misconception that bipolar is only for grown-ups, but we know that in children, sometimes these symptoms, we can see them even as early as 10, but we're always mindful not to diagnose mental disorders in children before the ages of 16, because, as I'm sure you're aware, Rexford, their physiology, their body systems, they're still going through growth spurt. And it may be conduct disorders, it may be, a growth spurt, but anything that worries you as a parent, you want to really to record it down and have that with you when you go to see the clinicians.
Awesome. Thank you so much there. So when it comes to support, and then also the question about cure, is there a cure? Let me start with that. Is there a cure for bipolar affective disorder?
I mean, there is no known cure for bipolar affective disorder, but I think it's important to emphasize here that individuals with bipolar affective disorder, like any other individual with mental illness or mental disorder, can be supported to stay well during episodes using a range of interventions. And I think the benefit for us who live in the Western sort of civilized societies is that there is actually quite a lot of these interventions, but there's always a question of whether that for the individual who has that mental disorder is willing to accept that help, so just to put it summarily, there is a range of medications that actually have been known to help reduce the severity of the symptoms of bipolar. And research has clearly shown that people that actually remain treated on medication alongside other maybe psychosocial interventions, and by that I mean things like maybe counseling, psychological support, but also sometimes we underestimate the power of love from our loved ones, family members. Again, we know that service users or patients who have that direct support and input from their loved ones actually have better outcomes than individuals without that support. But also, even things like that are not prescribed. Healthy eating. We often underestimate the power of having enough fruit and vegetables in our diet. In fact, one of the things I think I referenced earlier is in terms of thinking about the causes, is the different imbalances of neurochemicals in our brain. And in fact, things like dopamine, which is kind of the happy neurotransmitter, and serotonin, they, in a way, the body makes them by relying on the foods we eat. So it is important for us to just bear in mind the foods we eat, and to also to just help us to reduce, particularly the stress around us, because stress actually has been known for many years, even through ancient civilizations, to determine and influence the course of not only mental illness but also physical medical problems. So there's no exact cure for bipolar, but we know that there's a range of interventions that, if used religiously with the right support, sufferers can actually live normal lives. I have known people with bipolar who have not had a relapse for nearly 20 to 15 years. Why? Because of some of the things I've talked about. And I think that is important. That is important. The other thing I think to think about in terms of support and management, again, referencing children particularly, because when I worked in general practice, I did really reference and see quite a lot of adolescents and children. And I think many of the primary care physicians, not through a fault of their own, did not really sort of understand that, some of the symptoms they saw in children could be, maybe a bipolar illness. So again, for parents, it's important that if you're identifying some sudden changes in terms of mood variability in your children, as I said, keep a record of a diary. The variability, is it linked to school? Is it linked to bullying? Is it linked to maybe fear of, particularly in London, thinking about London, there's a lot of gang culture, and, children may be sort of groomed and all of that. Any of that psychosocial stress, adults deal with that stress differently to children. For children, that stress may be manifested in terms of, sudden burst of anger and breaking things, and maybe sort of being defiant and all of that. So it's important to understand whatever is happening around the child, and bring up those issues, be quite clear in terms of engaging the school, your concerns, because the school may also actually have similar concerns, and you may want to speak to them about them. Also, monitoring people's sleep. As I said, sleep is particularly important for people with bipolar and anybody with a mental illness. In fact, we all need sleep, and that for our body to function, for the normal physiology systems to function in our body, for our body, we need a good sleep. And particularly for children, they need an average of 10 to 12 hours. So if you feel that sleep has been compromised, whether you're 65 or 45, the one thing you're going to want to think about: why has my sleep been compromised? What am I doing wrong? What can I do to undo that? So again, making sure that you can educate, advise patients who may be having problems with sleep. Drugs and alcohol as well, I've talked about that. There's always a risk when patients are going manic, they will always want to self-medicate or even get higher and higher. And particularly thinking about drugs that may give you that euphoric state, you feel invincible, you feel happy and all of that. So you want to advise that, actually that in the here and now, they may feel good about it by using, these psychoactive substances, but on a longer term, it actually is detrimental for their mental health. So again, keep an eye on that, but also during recovery episodes, to make sure that you re-emphasize, what we call relapse prevention approaches. So understanding, helping the person to understand, so when I'm manic, why have I become manic? but you can only do that when the person is recovered, because when they're manic, when the patient is manic, sometimes it may be difficult to get through to them, so utilizing those inter-episode recovery sort of sections to try to see whether they actually remember many of the things they did in their manic phase. I remember this woman I cared for many years ago. She was extremely creative, and during the manic phase, Rexford, I'm not lying, she's an artist. She used to prepare those abstract pieces of art. She used to do about 10 abstract pieces at night at the expense obviously over sleep. And when she was better, she could not believe that she used to do that many art pieces, but they were fantastic to look at. And again, just thinking about, because for this particular lady, she was enhancing her ability to stay up, to be able to be productive by using alcohol. So again, I worked with her to try to see whether we can reduce the amount of alcohol, but also regular therapy sessions for individuals. That may be privately if you can afford it, but also for secondary care, if you feel that you need to talk to a therapist to talk about how you can actually understand your illness. Therapy sessions, I kid you not, they really are helpful alongside medication. The other thing I think I've talked about also, continuously evaluating the safety of the patient, and the safety of others, determining where appropriate will the patient or the individual require or receive support and help. If you feel that you're a family member and you feel that the patient may require much more support than you can give in your own home, that basically could be that they're highly at risk of harming.
Okay, we've lost Herbert momentarily, but he's just right at the tail end of what he is presenting. I'm sure he would connect again, but I'm sure you've been very much enlightened by the things that Herbert has been sharing with each and every one of us today. I'm not sure if you have any further questions that could be picked up. Thank you. I can see, yes, this is amazing and powerful information. Great. Thank you so much for that. And all the other comments that have come in. Right. Okay. Yes. I can see a question here. Yes, it's been answered. Thank you so much for that. Yes, we lost him for a minute there. We'll just let him come back as he wraps up before we finally close the session. If you still got any questions, you can still drop them in. I'm not, Herbert should be falling back in here in a minute. Right. It might be a good time to just remind you that if you have enjoyed today's session, please make sure you get some other people to watch this. Share the link with somebody else. It may not necessarily relate to you, some of what was discussed today, but let it help somebody. I know he said a lot of things about parents and how you should look at our younger ones, and even in the adolescent years as well. Any scenarios that we see that do not look great, we should be able to handle those ones quickly by keeping a diary, and then also he's back now, by keeping a diary and then also seeking the support that is available. Right. Okay.
Yes, I think my internet went.
Yeah, that's fine. That's fine. I realize you're gonna. I told the audience that you'll be back in there. So yeah, I was just recapping your points for them. And right. So yes, you just were on the tail end of the support systems. You talked about the diary, keeping a diary, and all that. In closing points, what would you say to maybe a parent of maybe an adolescent or somebody who knows somebody like that in a workplace and all that? What advice? How do they handle it? Do they have a conversation with the person? What can they do?
I mean, it's important first and foremost, because one of the things I think we do nowadays, because we live in a society where information is given to us everywhere on the internet, and we all become doctors, we all become psychiatrists. So one of the things you don't want to do is to go in and immediately label somebody as being bipolar or manic, one of the references you used earlier, because that actually will serve as a negative, So what you want to do really is to try to understand and explain, or maybe investigate, not necessarily, directly, but just try to understand whether the individual is struggling, because many people may be struggling for one reason or another. And it may be that they're just struggling because of a psychosocial issue. Maybe they've broken up with a girlfriend, or maybe because, they're poor. There are many people in England who are poor, and they may be going to work, but they're actually poor, So it may be actually small things, that may actually require, a bystander's ear to actually listen. And that if you then come at it from a brotherly sisterly point of view, that you actually understand where they are, and that are they considered to seek help. To seek help basically means, have they gone to their GP? Because in England, when you think about having a health issue, the first person you're going to want to consult is your GP. That is just really the system in this country, really. So you really want to just be understanding. Don't be judgmental. Don't use labels. And I think particularly talking to individuals here from a Black background, Africans, Afro-Caribbeans, and also individuals from the South Asian continent, there is a tendency in my experience for us to minimize or to belittle individuals who may have mental health problems or mental health issues. Or, well, you know what, that's not really an issue. Just get up, go to work, and what we're doing there is really not validating how they are feeling. In fact, the next time they want to be to open up about their worries or fears, they're not going to come to you. So it is important for us to come at it from a brotherly point of view, that, by the way, I understand you may be struggling. Is there anything I can do to help you? I have seen that maybe you're doing this, you're doing that, perhaps maybe there's a reason. Do you want to talk about it? You give them that opportunity to say that they have a voice, and again, quite often, one of the concerns and reports of people with mental health disorders, that they often feel like people don't listen to them, even when they're sectioned and they go into the hospital, the things are being done to them as opposed for them or with them, if that makes sense. So you really want to come from a point of, understanding, and not, putting people in a box, because when you put me in a box, believe you me, after 5 or 10 years, if I feel like I want to be in that box, I'll remain in that box, and that for you to get me out of that box, it's not going to be easy for you to get me out of that box. And that, I mean, Rexford, because there are many people in the system, in the mental system in this country, who have been, under so many psychiatrists, they've been under so many nurses, they've been under so many hospitals, that when they are in hospital, often for them it's the most preferable place to stay, as opposed to being outside the hospital. In fact, we want people to be out there in the community, to engage with the community, for the community to engage with them, if that makes sense. It costs less for the public payers money, and also it helps people to integrate back into society, if that makes sense. So really, if that was your friend or your colleague at work, you want to come at it from that way, but also just to say that there is a lot of support for them, both at work, because, if you work in an environment where there's occupation health, you can say, well, have you actually spoken to them, and so on and so forth. Yeah.
Wow, it's been a wealth of information, Herbert, there. Thank you so much for the session here. And I'm sure our audience has been very much enlightened. And again, I want to appreciate you for coming again and sharing these wonderful insights. I just love your passion when you're talking about different things there. Of particular interest to me is the fact that the whole misconception for young people as well, which you fully address. And so thank you so much. To our audience, thank you for joining us for another episode of Prime Focus. If you have benefited from this video and you know somebody else is going to benefit from it, please share it. Share it. Don't delay. Just share it with people. As Herbert was just saying there, we don't want the people in hospitals or always so in hospitals. We want to integrate them in society. Let's do our own part as well to make sure that these people are understood and we can all walk the journey together. So please share the link with as many people as possible and subscribe to the channel too. Right. So thank you, everyone. And Herbert, again, it's been a pleasure having you. And
Likewise.
get to see you again at some stage. Thank you.
Definitely. All right.
Yeah.
Bye-bye, everyone.
All right. Thank
All
you.
right. Thanks,
Okay.
Rexford.
All right. Thanks to our audience. Thank you for joining us as well. And as always, we appreciate you being part of Prime Focus.